Today we have two special experts, Dr. Stacy Lindborg, CEO of the IMUNON, and Dr. Premal Thaker, oncologist at Washington University, to discuss the OVATION-2 study and novel immunotherapies for ovarian cancer. You are welcome.
Thank you.
Thank you so much.
Thank you for joining us today. And I have some notes for our follower. Please feel free to submit your question throughout this webinar in the comment section. So we may move to first question. I will be happy if you give some information about your professional journey and the mission of the IMNN.
Hi, I'm Premal Thaker. I'm a GYN oncologist at Washington University School of Medicine. I run our clinical trials and the director of clinical research at Washington University, and as well as the interim chief of GYN oncology. I've had the pleasure of working with the IMUNON platform for over a decade, and so excited to share the excitement around this molecule with you today.
Great, and I'm Stacy Lindborg. I'm President and CEO of IMUNON, and from a career standpoint, I've been in the pharmaceutical industry for close to 30 years, and I'm very excited by the goals and the mission of IMUNON as a company. Broadly, our goals are to translate scientific research into commercial products that help patients. Our mission for IMNN-001 is to evolve the standard of care and to become the first immunotherapy to achieve a clinically effective response in ovarian cancer. And we are on the cusp of starting phase 3. So we're excited to have this conversation today.
Thank you very much for joining us again. And could you begin by sharing the latest positive top-line data from the OVATION-2 study? What were the key findings?
I can run through the findings, and then maybe you could add your clinical perspective to this. So when we start with the trial, so this was a design that was looking at neoadjuvant treatment followed by debulking surgery and adjuvant treatment in newly diagnosed patients with ovarian cancer. The findings which we shared, which are certainly offer incredible promise as we're looking to the future. When we start with the full trial, so the intent to treat population, we saw a hazard ratio of 0.74, which means a 35% improvement in overall survival in patients that were receiving IMUNON plus standard of care, which is platinum-based chemotherapy, compared to NACT or platinum-based chemotherapy alone. The median overall survival was extended by almost a year in this experimental arm of IMUNON plus NACT. And so when you think about the median overall survival in women in the standard of care arm, it was 29 months. Women lived 40 months in the experimental arm. And in the context with a cancer that has not seen a change in the standard of care for 25 years, we were very excited by this overall treatment effect. When we look at various subgroups, the data gets even more compelling, including examples such as for women who received a higher number of treatment cycles, they did better. So as we shared in our press release, if we look at women that got at least 3 doses of experimental treatment and at least 1 cycle of chemotherapy, the hazard ratio moved from 0.74 down to 0.64, and the median overall survival was extended by 15.7 months. So a 56% improvement in standard of care, which again is certainly remarkable given the historical landscape. And then following this with PARP inhibitor use, so PARP inhibitors were allowed as part of maintenance therapy in the study. And the experimental group, so those women treated with IMNN-001 in addition to chemotherapy, saw an even greater clinical benefit. The hazard ratio, again, to remind you, in the ITT group was 0.74. It dropped to 0.41 in this subgroup. And we know from the literature that this women with genetic mutations, which are most likely to be receiving PARP inhibitors, are expected to do better than the broader population. And in fact, we saw this with the standard of care arm. So in this group that received chemotherapy, received PARP inhibitors, the median overall survival was 37 months. It was 8 months longer than the broader ITT population. But in the experimental arm, the median overall survival has still not been reached, resulting in this really small and remarkable hazard ratio of 0.41. So those are the results in overall survival. We released progression-free survival, which really was very encouraging because it showed a benefit of IMNN-001. I think we could certainly walk through this data, but the definitive endpoint of overall survival, I think, was really the great place to start, and to really just comment that we will be releasing more endpoints in the public domain. And what's very exciting and encouraging is that there's consistency in the data across endpoints and subgroups, which really does give a lot of excitement and hope that this meaningful improvement that's observed here will be able to be replicated in phase 3.
So, thank you, Stacy, for sharing the interesting results from OVATION-2. It's quite impressive because we've been all in ovarian cancer trying to get immunotherapy to be a great adjunct with our standard of care chemotherapy. And this is the actual first molecule to show a benefit in progression-free survival and especially in overall survival. It's really exciting to see that there's such a synergy with our PARP inhibitors, because PARP inhibitors, as we know, has revolutionized our treatments. However, there's lots of women who still are not cured from that. So since we also have data that's showing that these women even have a better overall survival that seems to be improved with the synergy, it's quite exciting to see this immunotherapy interacting with PARP inhibitors. So this could really change the standard of care, not only for our patients who have HRD mutations and BRCA, but also for the intention to treat patients as well, which are really the ones that have the least options at this time. So I think we're really on to something, and hopefully we'll be able to benefit more women in the future.
In the OVATION-2 study, IMNN-001 is combined with the paclitaxel and the carboplatin. What influenced the decision to use this specific combination of the treatment? And how do you work together to combat advanced ovarian cancer?
So great question. Standard of care has been established for now over 25 or 30 years with the use of platinum agents and taxanes. And now we also have phase 3 data saying the use of adjuvant chemotherapy with interval cytoreduction, like we're doing on this trial, also has equivalent outcomes as primary debulking. So really, we're just trying to add on to standard of care, because our 5-year survival for patients who are found with advanced stage ovarian cancer, which is usually stage 3 or 4, is as high as 40 to 45% in stage 3 patients, and as low in stage 4 is about 15 to 20%. So we have a lot of room for need for improvement, and that's why novel agents such as IMNN-001 is so important.
IMNN-001 leverage IL-12 via TheraPlus technology. Can you explain the mechanism by which IL-12 enhance the anti-cancer immunity in the context of the ovarian cancer?
Right. So IL-12 we know is a very powerful cytokine and very important in immunotherapy. But up until now, there's just been so many side effects with how IL-12 could be given previously with humanized monoclonal antibodies. But with this new technology, we have a DNA plasmid that helps make IL-12 locally within the tumor microenvironment. So really alleviating the side effects that we've seen previously with IL-2 inhibitors. So we don't see the fever, we don't see cytokine release. And IL-12 has so many options. It helps with immunotherapy, both adaptive as well as our T cells and NK cells, and as well as our anti-angiogenic mechanisms. So all things that are very important to fighting cancer biology. So it's really important that we've been able to harness the benefits of IL-12 without the side effect profile. So it's been, studied extensively for decades, but now we're on to some mechanism that we can actually safely administer this for patients.
Yeah, and I would just add to that, as we've looked at the learning and the attempts from the past, Premal, you talk about the toxicity and the ability to really safely get IL-12 into the local tumor environment. I do think that there are aspects about IMNN-001 in terms of really using a DNA plasmid, a delivery system that protects the DNA from degradation by the body and facilitates DNA uptake by cells and transport through intracellular compartment without excessive breakdown. So really, when we think about the durability and IL-12 actually being able to have a longer effect, which would be expected with the survival outcomes that we have, we think this is playing into it. And I think the strategy of delivering IMNN-001 directly into the local tumor environment, we know IL-12, like most cytokines, function through paracrine and autocrine mechanisms. And the ideal targets for IL-12 immunotherapies are immune cells within the tumor and nearby lymph nodes, not lymphocytes in circulation. So the strategy of really targeting the local tumor environment and really maximizing the amount of IL-12 that's reaching the tumor, in addition to safety, we believe this really could be driving the most robust anti-tumor response.
Absolutely, Stacy. I think it's important to know that we're delivering the molecule intraperitoneally, and you may have said that before. So we're getting it into the direct tumor microenvironment, as you mentioned, and why it's so critically important.
How long do women with advanced ovarian cancer typically live on the current standard of the care therapy? And how have PARP inhibitors changed that?
Right. So, women, we're trying to make women have this as a chronic disease of ovarian cancer because we have lots of agents that can help. But if you talk to any patient who's had cancer, the real benefit we want to try to get for our patients is cure and hopefully never have a recurrence. So really trying to move molecules into the upfront settings, such as the chemotherapies that we mentioned, but also other agents to help will be beneficial. And so far we've tried to use like bevacizumab in conjunction with Taxol and carboplatin, but we've never seen an overall survival benefit with the use of a VEGF inhibitor. And now we are seeing overall survival benefits with the use of IMNN-001. So we're seeing that this immunotherapy is really helping patients. And as I mentioned earlier, it's helping all patients, but there's a special synergy with patients with PARP inhibitors. And PARP inhibitors have helped a select patient population much more. And so it's helpful that we're making beneficial strides, but we're really doing this hopefully for a greater population of our ovarian cancer patients with changing the immune environment.
Could you discuss the IMUNON safety profile observed during the OVATION-2 study? IL-12 has a history of the adverse event and intolerability. How does the IMUNON overcome this issue?
Sure. So we did see some side effects, and most of them were myelosuppression, such as, decreased white counts, decreased hemoglobins. But part of what we also think is on the OVATION-2 trial, we were checking labs on a weekly basis. So if you check labs when you have patients even on chemotherapy weekly, you will see them what we call natering down with their counts. So we don't really think that was something that was insurmountable. The other things we do see is we see abdominal pain because we are giving it into the intra-abdominal cavity. But we were able through the trial to give pain medications as well as anti-anxiety medicines to help patients overcome this discomfort. And I think Stacy probably mentioned that, we did see that patients got a benefit with the use of IMNN-001 as long as they could get at least 20% of the prescribed dose. So it's also important to know that we're really making changes very early with the administration of our medication too.
What are the unmet needs for the woman with the advanced ovarian cancer? What is the market potential of the IMUNON considering the other treatments are available or in the development?
Well, there's a huge unmet need because, we have so many patients who are unfortunately diagnosed not only in the United States, but worldwide, who are suffering from ovarian cancer. And it is our second deadliest gynecologic malignancy currently. So we have a lot of room for improvement. And yes, there's a lot of medications being developed in currently, but as I mentioned, most of them are in later lines of therapy and not in the upfront setting. And upfront is where we really want to make the biggest impact, because we never want to have to tell a patient again that you're not cured. And we're hopeful that we're making a huge benefit by the results that we saw in OVATION-2. So that's what's really exciting, and we're hoping that our OVATION-3 or phase 3 trial will hopefully continue to show those promising results.
And I'll just add to that just some numbers, right? So from the International Agency of Research on Cancer, we know the worldwide diagnoses each year is around 300,000. In the US, coming from the American Cancer Society, we see roughly about 20,000 diagnoses each year. And so, if we expect that 80% are newly diagnosed, and assume that there is, when we look at patients that are eligible for neoadjuvant treatment, there certainly is a very sizable market that we believe, when we look at the fact that the entire population and intent to treat perspective are seeing benefit from our experimental treatment, IMNN-001. It certainly is quite interesting from a market perspective. You asked that very specifically, but very much so from a human standpoint of the potential, across the set of women.
As you prepare for the phase 3 study, what specific endpoint and or modification are you considering based on the learning from the OVATION-2 study?
Yeah, I can start. And I think you certainly won't be surprised that the trial design will look very familiar to OVATION-2, which is often the case in confirmatory trials. But we're really, the main modifications will come from learning from this trial. So, phase 2 provides a really rich environment. This was the first trial where we actually had studied in the adjuvant setting. So neoadjuvant followed by surgery in the adjuvant setting. And, the key things that will look different are the primary endpoint. We see this really outstanding response in overall survival. We believe the ability to measure and see this kind of effect in in this trial certainly really demands that this is a very important primary endpoint, going after the definitive endpoint. When we look at some of the components which Premal has remarked on, this genetic mutation and those that are likely to respond to PARP inhibitors, with the really the response that we've observed, it's likely we will be stratifying to make sure that we have balance across the treatment arms, and we can really bring very confident conclusions to this and not just rely on randomization. And I think the last point Premal also responded to, which is, we learned and implemented a prophylactic pain protocol in the phase 2 trial. We're able to see an effect as we look at women and their side effect profile and ability to stay and receive, much larger number of doses, improved upon the introduction of this prophylactic pain protocol. So this will also be a core part that really we think will set this trial up for success, and for the women who are included in the trial really to get the best treatment that we can offer in the study.
How does the collaboration with the academic institution and other organizations enhance the development and the clinical validation of this new treatment?
Yeah, it's an interesting question. I think collaborations are so critical in all of our endeavors in life, and certainly when you're thinking about advancing treatments, I could probably wax long on this topic. But I think the things that I would really highlight in terms of, what collaborations bring, access to expertise and resources. We bring different perspectives, and we have a shared goal of helping patients. But academic institutions often have specialized knowledge, cutting edge technology, research facilities that really can be critical for developing new treatments. Second would be interdisciplinary approaches. I think that collaborative efforts really bring together experts from different fields, different interdisciplinary approaches, and often that leads to innovative solutions. I'm thinking basic science, clinical physicians, clinical scientists, translational scientists, really as we're thinking across the development realm, bridging the gap and really going back and understanding biologically what we observe once we're in the clinic and even earlier, but combining diverse perspectives that leads to more robust outcomes. And then the last one is really improving the relevance and the sustainability of our trials. Our protocols have to be operationally feasible. We need to understand and be very clear on what's clinically relevant. And so this kind of collaboration really, I think, improves the relevance and sustainability, and ensuring that, that our trial is going to address real world needs and that they'll be likely adopted into practice. So, these are just some of the synergistic effects, but I think they really accelerate development and validation of new treatments.
Thank you very much for joining this webinar, Dr. Stacy Lindborg and Dr. Premal Thaker. It was a pleasure to have you in this session and to listen to your insight and expertise. We appreciate to everyone who follow us for this webinar. Please share your questions and comments with us. Thank you very much.
Thank you for the invitation. It was a pleasure to be with you.